Okay, thank you. So this is, you'll be pleased to hear quite a short talk, partly because I was conscious that there was lots of other discussions both today and tomorrow, and I didn't want to repeat, partly because I thought it would be better to allow more time for discussion, and I wasn't sure what was going to be most useful. So I've got some slides. This might be helpful, it might not be helpful. As I say, I'm not going to go on for very long, and then we can talk about any of these things or other things that people would like to. So this is just some general thoughts, the way of structuring this talk. I only had one slide I wanted to give you, but I thought I can't just give you one slide. So I constructed I thought I'd say some other things about comparing between countries. And I guess given the nature of the conversation, the idea of experts from Mexico coming to the UK, thinking about the conversations that we're having in both places. I'm not sure the UK is the place to come to find out how to do assisted dying. There might be other parts of the world that perhaps have got more experience than us. We're having some particular legislative conniptions. But anyway, we're here. So let's have a think about how do we talk about and compare between countries. Because actually, wherever assisted dying is talked about, everyone talks about other places in the world and says, but what about X that's doing better or doing worse in some vague way? So mostly what I want to do is to point to some challenges when we engage in that exercise, when we say, well, how about X? Here are some of the problems. So one of the problems we've alluded to that's come up several times already during the day is the challenge of language. These are just the words in English. And obviously, when you're contemplating assisted dying in a non-English speaking country, you're going to have your own kind of addition to these. So there's a kind of massive lexicon of potential synonyms or maybe not synonyms. We might want to distinguish between some of these. We might think that some of them mean slightly different things, and often, certainly in the ethics literature, we do want to make some distinctions between different types of practices. Other times we want to bring them together and say we're going to talk both, for example, about self-administered medication and physician-administered medication. Other times people want to separate those out and call them different things. Another point which has been made already is that there's lots of euphemisms that are used, sometimes for good reasons, sometimes for less good reasons, because people don't like talking about death. We've heard about the challenge that societies have. We certainly have. Maybe Mexico's more enlightened than the UK because of your Day of the Dead, that you're allowed to talk about death, but we don't talk about death here. And then there are the connotations. And the connotations are the stuff that goes underneath the surface. So when we talk about euthanasia, I often make the point that euthanasia is a thick term, but it's thick in both directions. So thick, philosophers talk about thick terms. It's a word that sounds like it's just a description, but it's got some implied ethical connotation. So it can either imply a good thing. If you read the Greek, we heard at the start of the day the Greek origin, and either it's all about a good death. Who could possibly object to a good death? Or for many, many people, it implies something radically different because of the history of euthanasia, the way that particular term was used by the Nazis for something that looked a million miles. But of course, that immediately gets brought up when people start talking about it. Suicide, we heard, should we talk about suicide? Suicide has massive connotations, particularly in this part of the world, maybe in Mexico too, because there's a massive, massive hang-up. Suicide's massively traumatic. Let's not forget that there may well be appropriate situations where it's appropriate to provide assistance to somebody who wishes to die. But most suicides are not like the types of assisted death that we're talking about. They're individuals who are making impulsive decisions, often in the context of crisis and mental illness. So those are enormously damaging, and that's exactly the reason why people are anxious about the term of suicide. So to start off with, one of the things that just to recognize is that when we're talking about countries, we start using language, but the terms that we use, they work differently in different places. A word that works in this context doesn't work somewhere else, and vice versa. here's a great example. So this is euthanasia. This is the Dutch term euthanasia, which means actually something quite different from how it's used in other parts of the world. So one of the things is, by definition in the Netherlands, it's understood to always apply to voluntary euthanasia. So the idea of euthanasia, active ending of life for somebody who lacks capacity, can't be called euthanasia in the Netherlands because it doesn't mean that. The protocol, another unfortunate term in relation to active ending of life in newborn infants, isn't called euthanasia in the Netherlands because it doesn't fall under that definition. Now, even though the Netherlands, they famously do include some deliberate, they call it in deliberate ending of life or something like that in patients without capacity, newborns famously, they use a different term for that. So just to highlight that these words mean different things in different places. So that's a challenge when we're talking about what's going on in different places. Here are some other words that have particular meanings. And these look like much easier terms than all the soup of other terms. But what we mean by an adult means different things in different places. So there's the legal definition of adult, which, as I understand in Mexico, refers to 18. But in terms of many legal decisions in England, those translate to at least 16 or 17-year-olds, definitely to 16, 17-year-olds north of the border. So there are these types of ambiguities. And of course, in other parts of the world, adulthood legally is later in life. It's 20 or 21. So again, these are the easy terms, but they mean different things. The language of capacity and competence, again, we throw it around when we're talking about assisted dying, but they have very specific legal meanings. So capacity in this country has a very specific legal meaning. Even best interests, we heard best interests in reference. Actually, as soon as you start talking about best interests in this country, that immediately has a particular legal implication because it's written into the Mental Capacity Act. So that there are these things that from the outside you don't realize, but certain types of words have particular connotations, legal connotations. There are questions about what counts as medical treatment. So we heard already, does assisted dying count as medical treatment? And of course, the kind of questions of terminal illness, that both the definitions and the words, those have different meanings. So it's really just to acknowledge that the words that we use when we start having conversations already include some challenges for us in having these conversations, in making these comparisons. Okay. Next, I wanted to make a point that I often make in ethics, which is about a particular type of argument, and it's an argument based on comparison and consistency. And this comes up in lots and lots of areas in ethics. It points to situation A and situation B. It says that A and B look similar, but we treat A and B differently. And then usually the implication is that therefore we should treat B as we do A. So there are several things to observe about this particular argument. So one is, whenever we do a consistency type argument, is that it's appealing to what we might think of as a meta ethical value, which is the idea that when we engage in ethics, that we're trying to be consistent. We're trying to reach the same sorts of decisions. When the factors are the same, if we reach a different decision, it looks like we're not engaging in ethics. We're doing something else. We're doing random number generation. We're just kind of making random decisions. So that there is a claim, a plausible claim, that whatever else we might think ethics involves, if it has to involve a certain type of consistency. But one of the important things when in recognizing the consistency argument is that the argument itself doesn't do any work. It doesn't tell us where we should go. So if we say A and B are similar, we treat A and B differently, we have three different options. I've mentioned one of them. So one of them is that we treat B like we treat A, or we treat A as we do B. So, for example, A is legal, B is not legal. So, for example, suicide is legal, assisted suicide is illegal. Suicide, assisted suicide are similar. We could make them both illegal, we could make them both legal, or we have a third option, which is we say there's something relevantly different, there's a reason for treating them differently. Those are the three plausible solutions. Every time someone comes up with an argument, often people will jump to the conclusion they want to, which is suicide's legal, assisted suicide is illegal, we should make assisted suicide legal. But if we're just working at the level of the kind of meta value of consistency, we could take these other two routes as well. We could say, oh, let's make suicide illegal, or let's find some difference between suicide and assisted suicide. This clearly applies when we're thinking about cases, particular instances, but it also maybe applies between policies or between countries. Of course, when we start thinking about different policies, even more when we think about different countries, and I'm going to come to it, I think, in the next slide, most of the time, we're going to actually say, well, there's something different. So although the law is different between this part of the world and that part of the world, there's quite a lot of things that are different, and maybe that justifies it. What does get interesting, of course, is where you have a country with laws in various different bits of the country. That looks much more kind of weird, that there are these cross-border differences. So in the United Kingdom, we already are seeing this is about to occur. We've got two, as some of you may be aware, we've got two small islands that have now virtually passed assisted dying laws. There's a question very shortly. It seems likely that Scotland will pass some assisted dying laws. So there will definitely be these differences within a country that looks like it's got the same sort of background, the same broad legal system. Obviously, there are some differences that have led to this. So there again, there's some interesting questions. So what differences might lead? What justifications might there be for coming to different conclusions? Say Mexico reaching a different conclusion than the United Kingdom about what assisted dying should look like. Well, one difference is going to be values, on the plausible basis that these are ethical laws and that they should be based upon the values of a particular society. So here are just I picked some of the values, the things that we think of are important. Philosophers talk about values a lot, but often don't define what they mean by values. Let's say they're the things that we think are important. So these are a range of different things that plausibly we might think are important, that are going to be relevant to assisted dying. We might think some of these are more important than others because we might not be able to maximize all of them. We might think they're all important, but to some degree they're going to conflict. So different countries, depending on their choices, the choices of the politicians, but hopefully those choices are reflecting the values of the population, they're going to end up with potentially different laws. Here's another significant difference, and I was conscious of it. I might have missed some of the discussion earlier, but I think it's highly relevant to thinking about how assisted dying might be introduced or how it might work, is in relation to the structure of the healthcare system, how that might affect it is in several different ways. So it might be relevant in terms of the availability of resources, particularly in terms of the availability of healthcare, the availability of people to provide assisted dying. Alberto alluded earlier to challenges in countries where there are very high rates of conscientious objection in terms of availability of termination of pregnancy, availability of alternatives. So in particular, one pervasive question is about the availability of palliative care for patients with terminal illness. So we might think that that's relevant to whether or not the option of assisted dying should be available. and in terms of the resources required to be able to provide assisted dying. So I alluded already to whether or not there were professionals available, but one significant difference, one important consideration in thinking about frameworks for assisted dying is whether this is understood as a positive right or a positive right to assistance, or whether it's a type of freedom. It's permission for somebody to be able to provide a regulated service. If you think that it's a positive right, then you have to make sure that you've got enough health professionals who are available to provide it. If you think that it's a freedom, then the state simply takes away the bar that prevents it, and then that allows then people to provide that. So that will have implications for, again, across a very geographically very large country, much more significant challenges in terms of accessibility for people in remote areas, if you think that it's a positive right versus just a freedom. And I probably meant to mention it earlier, but the other significant thing, which was alluded to earlier, is in terms of the costs of treatment, the availability of publicly funded healthcare. So if you have a safety net, a healthcare system with a strong safety net that provides healthcare, and then you have the option of assisted dying, that's going to look very different than a healthcare system with massive inequality and large numbers of people who are unable to access basic levels of healthcare. This is not to say that there's a particular answer in different systems, but just to reflect that what is going to be right and what a country is going to feel happy with is going to depend upon these other contextual factors. I can't remember where it comes, or maybe it doesn't come up on my slides. One of the things I've often reflected is the peculiar context of the Netherlands, where there's enormous strength in family medicine, in the local general practitioner, where families have a close relationship with their local doctor. In that context, there's an expectation that by families and the community, that if somebody needs assisted dying, that their doctor, the doctor who they know and have had a relationship, is the one who will provide that service. But there's a very different expectation in healthcare systems where there isn't that enduring connection, and it works both ways. There's an expectation by the community of the general practitioners, but also of the general practitioners that this is something that they feel that they're expected to do as part of their care of patients. So that I think is a way of kind of characterizing how assisted dying might work very differently depending on how the healthcare system is structured. We've heard some of the very significant legal structures in relation to Mexico. We haven't talked particularly about the legal framework in the United Kingdom. What I want to talk about in particular is an argument that comes up all the time when we think about laws in relation to assisted dying, and whether or not particular proposals are a good idea or not. So this is the famous slippery slope objection. This is one of my favourite cartoons. This is based on something that a conservative politician who's in the bottom left corner. Anybody know who that is? There's Rick Santorum, who's a famous in his era. I don't think he would even be the most outrageous right-wing politician in the current era, but in his time he was pretty out there, and he in response to legalizing same-sex relationships at the time suggested that permitting legal same-sex relationships between consenting adults was going to lead to bigamy, incest, anything. These sort of slippery slope arguments in relation to assisted dying, they have this general structure which says, well, yes, we might say that this particular thing that you're proposing is allowed, but if that's allowed, that'll lead to something slightly more expanded, which will lead to something else, which will lead to something else, and you'll eventually get to, you'll get from something that looks like this. Anybody know what this is? So this is dignitas, and you will get by means of slippery slope to Nazi-style euthanasia. And that, and as a consequence, we should not start down a slippery slope. This is the caricature of how the slippery slope argument is. And because it's a caricature, it's very easy to dismiss. This is what people sometimes refer to as a straw man argument. Now, but some people do genuinely point to this type of argument, but I think it's very easy to dismiss. And usually, the simple way of dismissing it is to say, well, why is it? How is it that we're going to get from dignitas or whatever the current proposal is to Nazi-style euthanasia? So this is Janet, who might be still on the call, who I always cite when I talk about this. This is Janet's beautiful prose talking about, in the absence of positive evidence which never seems to be offered, there's no more reason to think that this would lead insensibly into killing people who had not expressed a wish to die than that shopping must lead to shoplifting or hairdressing to sneaking up and chopping off people's locks without their permission. So these sorts of kind of, I think, what I sometimes call sloppy slippery slope arguments are quite easy to dismiss. But there are other slippery slope arguments that I think are more challenging. And I think it's important not to simply wave away these arguments, to recognize that some forms of them have more force. So just to allude, there are three broad types of slippery slope objection. One is a conceptual type of slippery slope. So this is a version of a very famous philosophical paradox called the paradox of the heap, or the Socrates paradox. So if I have on the right here a heap of sand, and I remove a single grain of sand, removing a single grain of sand can't possibly turn a heap into not a heap. So then I take another grain of sand away. Taking a single grain of sand can't turn it not into a heap. But eventually, there's 2 or 3 grains of sand on the desk, and it's obviously not a heap. But it's never turned from a heap to a not a heap, because removing a single grain of sand can never do that. So there's something magical that's happened. Now, what this refers to are vague concepts. There are lots of concepts in the world that are vague, and actually there isn't a bright line between them. They blur from one thing to another. The great philosopher Derek Parfit talked about, just because we recognize that there's dusk, but of course there's also day and night. So there isn't a clear boundary between day and night, but there is this liminal phase between. But we do recognize that day and night exist as things. So there are ways of responding to conceptual slippery slopes, but there's definitely some conceptual slippery slopes in relation to assisted dying. I'll point to one of them in a second. Then there are logical slopes where, if we follow the logic of the arguments, we go from proposal A to B to C to D, and we might be led to something that seems quite different from where we started. And then there are the vaguer legal, conceptual, or empirical slopes, which point to what happens in the world when you start to introduce legislation around assisted dying. So here's the most obvious conceptual slippery slope. You obviously have a terminal illness if you're going to die in 1 minute's time. It cannot possibly make a difference between having a terminal illness and not if you were to be able to survive for 1 minute longer. That means you obviously have a terminal illness if you would live for 2 minutes, 3 minutes, 4 minutes, etc. It seems by force of this that you would have a terminal illness if you're going to die in 70 years, which then means that everybody has a terminal illness, which probably we do. So this is one of many concepts that are applied to assisted dying where there isn't a bright line. And we might say, okay, well, we just have to throw terminal illness out of the window, or we might say, no, there is something here. It's like day and night. There's a vague borderline. We can't say exactly where the line is. I'll point to 2 other options in a second. Here's an example of a logical slope. This is based on my much longer lecture on assisted dying, where I talk about different types of arguments that might apply both to passive and active euthanasia. So we might start from a premise that, of course, it's permissible to withhold life-sustaining treatments, like not perform CPR, but withholding and withdrawing are equivalent, so that means that it's, of course, also permissible to withdraw a treatment like a ventilator. Indeed, there isn't any ultimate difference between a ventilator and other forms of treatment like artificial food and fluids, which means that it's permissible to withdraw food and fluids. If we think about cases where somebody's going to have treatment withdrawn, they're definitely going to die, it seems that it would make no difference if we were to offer them instead assisted dying. They're going to die anyway. It's legal to take actions. These are, notwithstanding what the lawyers might say, these are definitely actions when these treatments are withdrawn. It seems like it would be permissible to provide assisted suicide in those, or voluntary active euthanasia in those cases. It seems paternalistic for people to make these types of decisions on the basis of disability or terminal illness, to say you can have access to this. So we might be led to believe that an autonomous person wishes to end their life, that they should be allowed to do so. We allow advance directives, so it looks like we should allow people to make the same decision on the basis of advance directives that we allow them to make if they have capacity, etc. So you can see that you can take a series of logical arguments and be led from something that everybody accepts and it's very clear, to something that looks much more challenging, starting to think about some cases of non-voluntary euthanasia. I know we've focused mostly today on voluntary euthanasia, but it seems, if we follow these arguments, that there is a case for these. Here's the other type of vague argument. I said we can dismiss the sloppy slippery slopes, but there are stronger arguments that people might give. So people might say, look, I'm not claiming that you're definitely going to end up with Nazi euthanasia if you allow assisted dying. It's just more likely that you'll end up with something terrible if you allow assisted dying than it is if you don't allow it. Or to put it the other way, if you don't allow any form of assisted dying, you cannot possibly get to Nazi-style euthanasia. So now both of those arguments seem kind of obviously plausible. It is more likely that you'll get to something else if you take one step. And if you take no steps, you definitely can't get anywhere. There's a further question about where we get to from that, because of course it depends on how likely it is that you would get to something else, or how important it is that it's made impossible that anything else could happen, or whether there are other ways of doing it. I think it's also worth acknowledging that many times in the public debates about assisted dying, in places where assisted dying is not currently permitted, those who publicly advocate, they say, look, we're only campaigning for extremely restrictive voluntary assisted dying in the face of terminal illness, etc. But sometimes the opponents say, yeah, but quite a lot of the time you talk about these other possibilities, including non-terminal illness and patients with chronic illness, or you might talk about mental illness, or you might talk about dementia and advanced directives, etc. It's all very well that you're only talking about this now, but realistically, you are going to talk about these other things if this first law passes. So it's not as if we're making up this possibility that there'll be further proposals, because you yourselves are inclined to talk about it, at least behind closed doors. So let's not pretend that there isn't any other possibility on the table. It's not what we're talking about right now, but it's there. Again, it's not to say that it necessarily follows that you shouldn't take the first step, but we can't dismiss the slippery slope argument just by virtue of the kind of really sloppy form. And I think that there's one of the points that is sometimes alluded to, sometimes not, is that the direction of change, wherever assisted dying is lawful, is in one direction. So my understanding is that no national assisted dying law has been repealed. the very few examples of laws being overturned. So in the state of Northern Territory, the law there was overturned by the federal government against the wishes of the local population. In Germany in 2015, and we've got some German experts probably online, my understanding is the very long-standing quasi-legal permissibility of assisted suicide was overturned by a criminal code, was made criminal by a criminal code, and then that was subsequently overruled by a constitutional court. So it wasn't a lasting rollback. So there is this sense of momentum, and that, again, this is one of the concerns of those who are opposed to assisted dying. Well, if we allow this, we're not going to go back from it. Now, I think there are two ways of interpreting this. One is, if nobody in the world repeals these laws, maybe that's because they're not as bad as people think. Or maybe there is some general social change that occurs once you allow these laws such that the community then doesn't wish to repeal them. Again, that might be interpreted in a positive way. It's not necessarily a negative thing. But I think that's, again, one of the senses in which this argument about slopes is not totally spurious. Okay, this is the slide I wanted to give, the only slide I wanted to show you. So I have a hypothetical for you. So here are two different countries. Country one says there's a constitutional right to this. And the question they ask, their lawmakers ask, is in what exceptional circumstances can this thing be limited? Country two says there is no right to this thing. They say, in what exceptional circumstances can we permit this thing? So my quiz question for you is, what are these two countries and what are they talking about?
Can be talking about a lot of things, right?
They could be talking about quite a lot of things because I've framed it very, very broadly. So you might think, so here's one immediate thought, though nobody's jumping up and down because they realise there's probably a trick. So one thought is that this country here, maybe this is the UK, is thinking when, and maybe this country here is Canada, and we're talking about assisted dying, but it's not.
Colombia?
No,
Brexit?
So this is talking about gun laws in the US and the UK. And the point of this slide is to say, if you imagine these two countries and think, what are the legislative regimes going to look like, and are they ever going to converge? It's manifestly clear, I think, that these two countries are going to end up with radically different answers that are kind of mutually irrelevant. So America's gun laws are irrelevant for the UK because they come from a very different place. The UK's approach to gun laws is irrelevant from the US because they come from a radically different place. They could look across the pond and say, what would it look like if we enshrined a constitutional right to bear arms? Or what would it look like if we scrapped the constitutional right? That's plausible. But the idea that, for example, allowing some people in exceptional circumstances in the UK to have firearms would lead to people having a right to concealed carry and automatic weapons is kind of utterly fanciful. And so this is my main point, which is in terms of the UK debate, when people look across to Canada and say, look at how Canada is thinking about assisted dying, most of that is utterly irrelevant for a context like the UK, for these exact reasons. Because it's just implausible that you would get from the context of the UK to Canada without an awful lot of steps and changes in between. So this is the last slide, which is just about responding to the slippery slope in general. So it comes up all the time in assisted dying. here are a set of ways of responding to the slippery slope. So if somebody makes the sloppy slippery slope, if somebody starts talking about Nazi-style euthanasia, then I think we're justified in rejecting it and saying that that's a distraction. It's utterly irrelevant to what we're talking about. If somebody makes a much more plausible claim and says, well, it's more likely or it's possible that if we pass this law, we'll get to somewhere else, then what we can ask for is the empirical evidence that Janet asked for. The evidence that if you allow hairdressing, that people will progress from that to stealing people's hair. So what we might look for is to say, okay, well, let's look at other legislations and have they progressively changed with time? And of course, there are some places that have, and there are other places that haven't. So then that doesn't really tell us whether one particular country is going to liberalize more over time. It's definitely possible for all the reasons that I've alluded to. It's more possible than if you don't make any laws at all. But that's all we can say. There's a possibility. If we don't want to do it, it's up to us. Of course, some people would say, it's not a problem, we've alluded already, to move straight to the much more liberal options of allowing assisted dying for anybody who has capacity, is not being coerced, is making a voluntary decision. So some people will accept that what's called the reductio ad absurdum, the step much further down that allows assisted dying in much wider circumstances. Or we could make a non-arbitrary distinction. This is, remember, the difference between A and B. There's a difference between, for example, voluntary assisted dying for a competent adult and non-voluntary euthanasia for a newborn. There's some big differences there. We can say one of them's allowed and the other one isn't because we can tell them apart. They're like day and night. It's not like we have to go from one to the other. Or if we're talking about something that's much more vague, like terminal illness, we can draw an arbitrary line. So if we want to say we want to allow some people to drive, but we don't want to allow 2-year-olds to drive, because that would be absurd, we're going to have to draw a line somewhere. It's going to be like the grains of sand where we draw it, but we'll have to make an arbitrary decision. And where we do that is going to depend on our values and what we think is important. But so we might say 6 months, not because 6 months is magical, but because we might have to make it draw a line somewhere. And that's where I'm going to stop. Thank you very much.